Hello, my name is Thakkar, and I am an assistant professor of orthopedic surgery specializing in hip and knee reconstructive procedures at Johns Hopkins Orthopedics. I primarily work at Johns Hopkins Howard County General Hospital in Columbia, Maryland, taking care of patients with hip and knee conditions. Today, I will be discussing when should you consider a joint replacement or a joint arthroplasty. The title of this talk is focused on when should you consider a joint replacement surgery and advances in the management of hip and knee conditions. Along with that, I will be debunking some myths associated with hip and knee reconstructive procedures. Before we begin, I wanted to introduce myself and give you a little bit of information about what I do. So I was born and raised in Mumbai in India. This is my lovely family, my wife Rashmi and my two kids. I grew up speaking several Indian languages. I came to the United States in 2001 primarily for educational purposes, and I trained at Johns Hopkins. I also trained at Hospital for Joint Diseases in New York, and I trained at various different facilities all across Western Europe in advances in hip and knee arthroplasty. I'm married, I have these two lovely children, and I enjoy traveling and photography as my hobbies. My work is primarily located at Howard County General Hospital in Columbia, Maryland, which is a suburb of Baltimore and a suburb of Washington, D.C., if you think about it. I also have clinic or office hours at Columbia, Maryland, and in Odenton, Maryland. Here is my contact information for your reference, including my phone number, my email, my website, and my office address. My specialty, as I mentioned, is focused on patients with hip and knee disorders. And this is a long length X-ray that covers an entire patient's lower extremity, all the way from their pelvis down to their ankles. And up here, where you can see my arrow, that's the region of the hips. Here in the middle are the knees, and down here are the ankles. So my specialty is basically focused between the hip and the knee. And as an extreme example, here is a patient who has really bad arthritis in both her knees. And when we can correct it, we can correct this deformity. This is what the end result looks like on the right-hand side. These are complex total knee replacements that we perform for this patient to give her mobility. Now, the types of injuries that are typically seen are sports injuries, falls, patients with arthritis, both wear and tear type of arthritis, known as osteoarthritis, and also inflammatory arthritis, in which the immune system attacks your own body and your own joints and creates destruction of those joints. And finally, I also see patients who've been involved in traumatic injuries like car crashes and have had hip and knee conditions. Now, what exactly is arthritis? So let's begin with an analogy. And I like to give this analogy of a car tire and a shock absorber. So as a car is running, if there is any change in the alignment of the wheels, any change in the balance, or any change in the shock absorbers, what tends to happen is that the tires wear out sooner than expected. And here you can see various different examples of how things change as a car is driven. And as the tires wear out, even the shock absorbers wear out. So that, simplistically stated, is arthritis. When there is any change in the alignment of your joints or some kind of trauma, some kind of injury to your joints, and that smooth surface on your joints gets degraded. So here is a very nicely explained or a very simple video of what arthritis means for the joint. This is from a website called Versus Arthritis. And what happens is arthritis tends to affect a large proportion of people all across the world. There are, people from different genders, different body types, different races, and arthritis is prevalent all across the world. It can affect your hands, it can affect your feet, it can affect your hips, knees, back. Those are the most common areas of osteoarthritis. Now, here is an example of what a normal joint looks like. You have a muscle shown here in pink. You have a bone or two bones, and then you have a nice joint with joint fluid which lubricates the inside of the joint. The synovium is that layer which generates fluid, which is known as the synovial fluid inside the joint. And that synovial fluid is contained inside a bubble, inside a capsule and a ligament, which contains this fluid and lubricates the joint. And the muscle acts on this joint to go ahead and move it. So as you see in this video, the muscle is pulling and pushing, and the joint moves, and it glides very nicely. Now, with time, the cartilage tends to become very narrow and become very thin. So it's nice and plump at the beginning of our life, and as time increases, as we gain weight, as we do more activities, that cartilage tends to break down. Now, normally, the body has a process to repair that cartilage. It can create a film, it can generate more fluid and repair that cartilage. But as time passes and as we age, that ability of the body to regenerate changes. The cartilage starts breaking down, the bone starts rubbing against bone, that balloon becomes larger. The weight scale increases because we gain weight. We try to perform more activities to try and stay nimble and try and stay healthy. We start taking medications to help control our symptoms, such as pain, such as swelling, and eventually the joint breaks down. But the key is, despite all of this, you want to remain active, you want to continue with your habits, and you want to remain physically healthy and mentally healthy to try and control your symptoms. That's the key. Despite what your joint feels, you want to maintain your activity levels. Now, there are several different treatment methodologies before surgery that we can offer to patients. We talk about anti-inflammatory medications. We can do physical therapy. We can give you an exercise regimen to keep you healthy and active. And we have a host of different injections that we can give patients. Many of you have heard about cortisone injections, which are steroid injections, which we can give in the joint to help reduce the inflammation. Then we have joint lubricating injections, which are the fancy term for it are hyaluronic acid injections. Those can lubricate and provide that fluid barrier inside the joint to prevent surfaces to rub against each other. We also have stem cells, and here's a video illustrating what stem cells actually mean. So another very simple video to give you a good perspective of what is stem cell therapy. Now, stem cells are those cells that can regenerate and help repair the damage that occurs in various different parts of our body. And they can happen, you can give them in cases of arthritis, ligament problems, tendon problems, so on and so forth. So stem cells typically are two different types. One that come from babies, or embryonic stem cells. Those are the best because they have the ability to do anything. They are the master plan in our body, and they can generate multiple different types of lines of cells that can help heal. And then you have adult stem cells. So what we are dealing with really with you and I are adult stem cells that we can draw from your own blood or your own bone marrow. Now, these stem cells can go in few different directions, not a complete different, not so many directions as the adult stem cells. So think about this analogy of a house on fire. All right. Now you have various different elements like the rain, the sun, weather changes. You also have, time, and over a period of time, that house on fire is going to break down. Now, in order to prevent that from happening, you have several different people like firefighters, contractors, maintenance folks, all of these people that tend to repair that house. The same thing for your human body. If you think of your human body as your house, you have several people. You have financial advisors, lawyers, dentists, doctors, all of these people trying to take care of your body. And all of us have various different roles. And we have to kind of act in unison. We have to act to keep you together. Stem cells work the same way. They act to put out fires, they act to repair joints. So if you have a joint that has arthritis, you have certain cells in green which act to repair it, And those are like contractors, those are like firefighters that act to really keep you healthy. And then you have certain cells which are in red, which are going to try and break your joint down. And there's a balance. There's a balance between damage and repairing your joint. And you want to have a happy balance. However, if one injury or one episode tweaks that balance more towards the damage side, that's when we have arthritis or joint damage. So that balance in the joint is disrupted. And that's what stem cells try to achieve. They try to give you that balance back. So as time passes, injuries, pain, things of that nature build up. You start feeling miserable. You don't like your activities. The contractors, the architects, the doctors, the lawyers, they kind of get pushed out of the equation, and you have other negative forces that take over your body. However, with time, we can draw out these stem cells. So there are several different sources. We can draw them out from your pelvis or your iliac crest. We can draw them out from long bones in your body. We can also draw them out from your bloodstream. We can take them, spin them down, meaning clean them up, and then inject them back into the joints to hopefully try and heal, try and give you a protective barrier for that joint to last many, many years, so that you have function and you have effective pain control. Now, there are several different factors that coordinate this and coordinate the healing that's associated with your damaged joints. And over a period of time, that healing goes about, and we can see how joints do over several months to years and how they heal. So that's a brief primer of stem cells. Now, if all the non-operative therapies have failed, we also have the option of performing partial or total knee replacements and total hip replacements. We typically only reserve partial hip replacements for patients with fractures, where the ball of their hip bone has broken off from the rest of their thigh bone. So here's a video that we have put together for what is a total knee replacement. And I encourage you to go online, to go on YouTube and look at this video. And it's in a question and answer format. I will skip to the part which is your knee, and then I will show you what a total knee replacement looks like. So here this is a video again explaining what a knee is. There are various different structures associated with the knee, like the thigh bone, the leg bone, the ligaments, the meniscus of the knee, the cartilage, which is the nice barrier, the protective barrier, the cushion of the knee. And what a total knee replacement looks like, as I'm going to scroll ahead in this video, is made out of metal and plastic. And now you can see that as I move that implant, how smooth that motion is compared to a patient that has an arthritic looking knee. Moving on to what a hip replacement is. Once again, we've put a video that you can access via YouTube, understanding what a hip replacement is. And this was specific to hip fracture treatment. So let me show you a bone model of what a hip bone would look like. So here I am holding the pelvis, and then here is the hip bone, which is the ball inside a socket. And a total hip replacement replaces both the ball and the socket to give you nice mobility into that ball and socket, or a ball and hinge type of joint. Now, in addition to understanding what those surgeries are, we also have several surgical advances in how we perform these surgeries. So here is a video of a robotic knee replacement, and this is a partial knee replacement. So in our operating rooms, we have access to a robotic system in which we can take a wand, almost like a magic wand, and paint the various surfaces of the bone. And then we can plan our surgical execution in how we are going to position those implants as we move the knee from extension, which is fully straight, to flexion, which is bending the knee. How does that knee perform? We can plan all of that out in real time. Then we have this instrument, which is a robotic instrument that we can introduce inside the knee after making an incision or a small surgical cut through the knee. And then that instrument will create a very nice divot into your bone. It kind of shaves down the bone that's worn out, and it creates these very fine-tuned holes in which we can position our implants. So that is done for the thigh bone, which is up here, and that is also done for the leg bone, which is down there. And these are nice implants. They're made out of metal and plastic, which then get placed into the bone. And you can see that now you have a nice, smooth gliding surface for the bone. You still keep your bone. It's just the end caps of the bone that get finished and that gets smoothed out by the system. Analogous to a knee replacement, we also now have technology to perform a hip replacement robotically. So this is a video that's made by Stryker, which is one of the implant companies that has this robotic system. And let me show you exactly how it works. So we take various different landmarks on your bone, and the robotic system lets us choose which landmarks to take. So these are landmarks that we're acquiring on your pelvic bone inside the socket. And again, we have that magic wand that goes ahead and captures this. And then once you've captured these landmarks, the robot comes up with a plan that the surgeon can approve or alter. And then it has a robotic arm that we can introduce into the patient. And here is an example of how we smooth out the socket. So we put this device that looks very much like a cheese grater inside the socket to go ahead and clean up that socket in a very precise fashion controlled by the robot. And eventually we can put our parts into the place, into the actual location using this robotic arm so that we don't move. And it's a very precise location of where we put these parts. So the question that we ask my peers or other orthopedic surgeons is recognizing that every patient that we see comes with a unique challenge in their hips or in their knees. And would we treat these the same way? And the answer to that question is no. There are various different treatment options for various different pathologies. So here is a patient on the left who only has arthritis on the inside of the knee and underneath the kneecap. Here's a patient in the middle who has arthritis all throughout the knee, but has a bow-legged pattern. And here's a patient on the right that has what we call a wind-swept deformity, meaning that the wind almost hit their right knee and took their left knee with it. So one side is a knock-kneed deformity, and the other side is more bow-legged. And the treatment for all of these is different. So if someone comes to me with very early arthritis, but only in very few parts of the knee, we can do partial knee replacements. So here is an example of a partial replacement on the inside and a partial replacement underneath the kneecap to give them mobility by preserving their ligaments or their brains of the knee. Here is a patient that came to me with a bow-legged deformity in which their legs were bowing outwards, which is a very common deformity in most of us. And I was able to correct that, however, maintain a slight amount of bow-leggedness, because if you bring people back to a completely straight knee, they're not very happy because they've walked on these bow-legged knees for a very, very long time. So making them completely straight isn't making them very happy. However, when you have a patient like this, who comes with this wind-swept knee, you have to make them straight in order to give them the correction that they deserve. So here are two videos. This is a video of the patient walking towards me with this windswept deformity. Again, look at her right knee and look at how it's getting knock-kneed and her left knee is getting bow-legged. And now here is a patient, here is the example of her walking 3 years after surgery, where her legs are completely straight and she can walk without any assistance or without holding on to the bed, the walls, things of that nature. So this is the power of joint replacement surgery. Now, those were knees. Here's an example of one of my patients, Miss Alicia Polsky, who has undergone a hip replacement. And I want her
I've
to
had
describe
arthritis for
what she
a number of
feels.
years, and I've had a knee replacement, ankle fusion, wrist fusion, various things. And the latest was the hip that disintegrated. was in an excruciating amount of pain and I could barely walk. I couldn't walk 2 houses down. It was scary to go to a hospital at all, but it was a separate part from where COVID patients were. Everyone was covered with a mask. We all used sanitizer. They took your temperature. It felt very safe. I went in the morning. I think I was there by 7 or so. In surgery by 8:30 or so, and perhaps by 2 o'clock or 2:30, I think I was out the door. So tomorrow will be 1 month since my surgery, and I'm trying to walk a little bit more every day. Now I think I'm almost up to a mile. Dr. Thakkar said I can try golf, I could go biking, I could do whatever I want. I was very lucky that he did not have a big backlog of patients, and I was able to get in relatively quickly. Because in Florida, there was such a backlog, I probably wouldn't have gotten in to see a doctor until mid-July for surgery. So I was able to save a month and a half of my summer by getting on Dr. Thakkar's schedule. I was very grateful because it changed my life. I'm now able to walk. I took a bike ride with my granddaughter the other day, which was great. And, we're taking walks down to the duck pond. So I encourage anybody to go ahead and get the surgery because you will feel better almost instantly.
So this, and I don't have to do any talking for this, but this is Ms. Polsky describing her own experience. And you can see that this is the power of joint replacement surgery. Now, there are success stories, but there are also a lot of failures that you may have experienced, or you may have family members or friends that may have experienced. And there are a lot of myths about the failures and about the successes of joint replacement surgery. So I wanted to debunk at least 5 of the most commonly held myths about what joint replacements are. But before we do that, I wanted to show you an example of how arthroplasty has evolved. So this is Sir John Charnley, or this was Sir John Charnley, and he came up with the modern total hip replacement as commemorated here in a stamp. He was a surgeon in the United Kingdom. And he performed experiments, he performed surgeries actually in this chamber where he would completely sterilize the chamber to reduce the risk of infection and provide the most effective procedure for his patients. And from that, we've evolved tremendously. So this is the modern operating room where here is an example of one of my colleagues using a robotic system. So we've come a long way. However, some of the principles that Sir John Charnley introduced and developed are still in practice to this day. So these are the 5 most common myths that I have encountered where patients ask me whether they need to be old, they need to be alone and lost in this process, they need to have excruciating pain through this process, their recovery is going to be slow, and they need to stay put in the hospital. And just like this TV show on Discovery Channel, which is called Mythbusters, I am going to be your arthroplasty mythbuster today and debunk some of these myths with some of the data that we now have. So let's look at this. What about age? I mean, do we really need to be old to get these procedures? Back in the day, it was like, well, grandma doesn't do much or grandpa doesn't do much. Let's get them this procedure so that they can break out of the shackles of being at home and go and enjoy an active lifestyle. But if you are young and if you have joint problems, wait until you get to grandma or grandpa's age. Well, that is a complete myth in this day and age. So here's some data showing how young active patients do with total knee replacements. And what this study found was that 85 to 95% of patients are very happy with their knee replacements at these various years of follow-up. Up until 18 years of follow-up, almost 85 to 95% of patients are happy and their implants are existing, meaning they haven't worn out. What about longer term data? What about 30 years? So this was a follow-up study that the same group did. And at 30 years, what they found is 70 to 82% of patients were satisfied with their implants and had their implants in them. So those implants survived in them for 30 years, between 70 and 82 or 85%. That's a tremendous number for needs. The same thing exists in hips. So here's a study looking at hip replacements in young patients. And what they found is that before surgery, the scores were in 40s. And 100 is a great score, 40 is a very mediocre score. And at 1 year, all the way up to 20 years, those scores were between 90 and 95. So excellent scores as time progressed in these patients, even at 20 years after these surgeries. And if you look at the implant survival in a short term, let's look at 5 years. What this study found is that the implant can survive in 95% of women and 99% of men. And that remains constant even at 20, 30 years. So these implants really survive in patients for a very long time, as long as we care for them. Now, this is a testimonial, just like Ms. Polsky's testimonial, of a patient that was published in a paper. And these are patients that are born with hip conditions that do not allow them to walk. So what the patient states is that at school, children were making fun of the patient for being so different because of his or her pelvic deformity and movements. And when the patient had hip replacements, the patient was 47 years old. Their life changed. They looked in the mirror. They did not believe their eyes. People who knew the patient did not recognize the patient. And 24 years have passed since the initial surgery, and the patient has had a normal life after that. So this whole thing about an age bar, an age limit, that is a complete myth. It's all about quality of life, which you want to preserve and protect with utmost sincerity. Now, the second myth is that patients need to be alone and lost in this journey. Are you embarking on this all by yourself? And that's not true. Here is an example of what we consider an episode of care. So what happens before surgery, what happens during surgery, and what happens after surgery. And there are various different facets to your entire episode of care, and you're not alone in this. We have an excellent team of professionals that help you through your entire journey. And by doing that, what we've achieved is the average length of stay. Now, this is data from 2013 and 2014, where the length of stay reduced from 4 days to 3 days. But now that's even less than a day sometimes, and patients are able to go home the very same day after surgery. What has also changed is in these purple, so this purple bar indicates patients going home, and blue bars indicate patients going to rehab facilities. And as time has progressed, more and more patients are going home safely, and fewer patients are going to rehab facilities, which is in your best interest in trying to go home to your controlled environment. And if you look at readmissions from these facilities, it's really no different. So going home does not make it any less safe. In fact, it's probably safer from a complications perspective. Now, again, I mentioned we have several different professionals that are ready to care for you. We have this academy called the Joint Academy, and this is the phone number at Howard County General Hospital where we can care for you and where we can provide the best possible service to you for your arthroplasty needs. So are patients alone in the journey? No, again, that myth has been busted and debunked. Patients are not alone. We have several different avenues for help. Patients must have pain. So, this is a common joke that none of us can compete against anesthesia or anesthesiologists because they can dose medications that can completely knock us out. Now, that is fine, but pain comes from multiple sources, and we want to achieve or we want to really look at a biopsychosocial approach. We want to look at biology, psychology, and then social factors that play a role in your pain. And we want to try and control or affect all of these factors to provide multimodal pain control. So here's just a fancy diagram that shows various different pathways that are controlled and that contribute to pain. And in this red arrow is the place where opioids or narcotics play a role. And in these green arrows are other agents besides narcotics. So you can see that there are more green arrows than one singular red arrow. So opioids or narcotics are a very small part of the pain pathway. There are multiple agents like anti-inflammatories, nerve medications that can help modulate the level of pains that you feel. And that's what we want to try and control. So here's a study, and we sort of do this inside the operating room where we identify the various different nerves that affect patients. And this is an example of the 4 different types of nerves that contribute to pain around the knee. And we can go ahead and provide an injection around those nerves to try and reduce pain levels both during and after surgery. We also have newer agents, sort of like this pomegranate, in which there's a barrier on the outside, and then there are small granules of the drug. And when you inject this drug, it gets injected as a barrier, but then the body breaks it down into these small little granules, these small little pieces of fruit. And then the drug slowly and steadily elutes or dissolves over time and provides sustained pain control. So these are some newer agents that we are using in our surgeries. And eventually, the pain is well controlled for our patients. So that myth of patients being in pain all throughout their healing process is completely false. And that has also been busted by the data that we now have with regards to pain management. Now, should the recovery be slow? Should therapy be really, really slow and take several months for patients to achieve? That has been a thing of the past, not so much a thing of today and a thing of the future. So here's an example of criteria that we use to discharge patients home the same day after total hips and total knees. They need to be independent, they need to be functional, they need to be safe using stairs, they have a good understanding of exercises to perform at home. And most patients are able to achieve this. And hence, when we look at reasons for delays in discharge from the hospital, physical therapy or physiotherapy is the least important reasons. There are various other reasons which hold up patients' discharge disposition. Now, what are the reasons for readmission? So there are various different medical reasons that bring patients back to the hospital. And when we look at this statistically and in terms of cost, you can see that it proves to be a pretty expensive endeavor for hospitals, for patients, for insurance companies. So we're really trying to minimize readmissions. And what is shown as a protective factor is walking on the day of surgery. So if you're able to walk and perform your activities on the day of surgery, there's a pretty good likelihood that you're not going to need to stay in the hospital for a long time. You're going to go home and feel safe, and you're going to keep building on that strength and prevent any further injuries to your joint and to your activity status. So in essence, rehabilitation or rapid physical therapy and rapid mobility is the goal, and that's what we are here to help you achieve. And therapy does not need to be slow. Your recovery does not need to be slow. The final myth is that you need to stay back in the hospital. The hospital is the best place to get care. And I would argue that for the most part that is true, but for a very short defined period of time. Any one of you that has been in a hospital knows that it's a chaotic environment. People are waking us up. Blood work is being done at odd hours. So we really don't want to disturb your rest and your healing process. We want to get you home as soon as possible safely. We can even arrange for home care nursing, home care physical therapy to come visit you with help you take care of yourself after surgery. So what are the outcomes if you go to a rehab facility? So if you go to a non-home discharge destination, there are several different factors as to why that would happen. And there are several different factors as to why you need to go to inpatient rehab facilities. But if you look at adverse events over 30 days, by going home, as shown in this green arrow, you actually reduce the percentage of adverse events, and that is protective. You reduce your readmissions, again, shown in this green arrow, as compared to going to rehab facilities. What happens if you have to have a revision joint or a redo joint? Well, it turns out that the same factors play a role as a primary or a first time joint replacement as in a revision joint replacement. And again, readmission rates are lower if you go home, and complication rates are lower if you go home. So what we need to kind of put a very clear message out there that hospitals and rehab facilities are very different. They are not symbiotic. They are not aligned in the goals that they want to try and achieve. In hospitals, the goal is to get you healthy and get you back home. In rehab facilities, they may keep you there for a longer period of time to help you get to your goals, but that therapy is extremely slow and that process is extremely gradual. And that may not be in your best interest, at least for a majority of the population. So you do not have to stay put in the hospital. You have that ability and that power to go home. And with that, I think that we have successfully debunked several myths associated with arthroplasty. We've given you the various treatment options that we have available for patients with hip and knee pain. And I encourage you to use this information to educate your friends, your family members. And if you have any further questions or would like to set up a consultation with us, please call us. Our number is 443 546 1540. And here is my email, here is my website, and here is our address in Columbia, Maryland. Thank you very much for your attention, and I am happy to answer any questions that you may have. Thank you.